I'm Kristen Sherrill. I'm here doing my cardiovascular advanced physical assessment. This is my patient. With any physical assessment, you first want to start out with an introduction. Hi, I'm Kristen. I'm your nurse. And you also want to ask for participation and if it's okay for us to complete this physical exam at this time. So, patient, is it okay if we complete an advanced cardiovascular assessment on you at this time?
Yes, ma'am.
Okay. There's other things that you want to do. So we've got the patient's consent. We want to ensure that there's adequate lighting. Positioning for the cardiovascular assessment. Most of it takes place in the supine position at a 30-degree angle. Okay. So first thing you want to do is inspection. You want to inspect to see if the patient's calm, her behaviors, if she's relaxed, any anxiety. Anxiety can be indicated of a myocardial infection or an MI. You also want to examine for pallor or cyanosis, any bluing of the skin. This is indicated of poor perfusion or lack of oxygen or hypoxia. So you want to inspect the arms, the face, the other arm, and also the lower extremities. And I'll do that at this time. Inspection is the first part of any physical assessment. We want to inspect, like I said, the pallor of any of the extremities, any scars, bruising. When we inspect the hands, we need to inspect for clubbing of the fingers. This is indicated of hypoxia or lack of oxygen, chronic state. So we know that there's no pallor at this time. When we examine the face, which is the first part, we also want to look for orbital edema. Orbital edema is an indication of heart failure. So I'm looking at the patient's face. There's no signs of orbital edema. Okay. So the first thing we're going to do is take the blood pressure. And we want to make sure that we have an appropriate size cuff. Just going to put this on the patient's arm. Going to have our arm midline to the chest to get accurate reading. We're going to find the pulse, the brachial pulse. I got a reading of 130/70. We know from the patient's health history that she does have a history of stage 1 hypertension, and she takes medication for that at this time. We next want to assess the heart rate. We can do this by palpating the radial pulse with the 2 finger pads. When we're assessing the radial pulse, we want to assess for irregularities, pounding, or any thready pulses. Irregularities can be an indication of a heart arrhythmia. We also want to assess the left side, excuse me. And then we want to assess them simultaneously too, to know any differences. And those are both within normal limits. The next thing we're going to assess is the great vessels of the neck. This includes the carotid pulse, or the carotid artery, and the JVP. So we'll first begin by assessing the carotid pulse. We can do this also with 2 finger pads or 3. We want to do these one at a time on the left and right side, beginning on the right. Pressing on the same time can cause syncope and decrease blood flow to the brain. So we want to assess this. Noting any irregularities, throbbing, or threadiness in that. We're going to assess the other side. And when we assess their carotid pulse, we want to assess it just medial to the sternobasaloid muscles. And when we assess these, we're going to slowly increase the pressure until maximal pulsation is felt and slowly let go. Increasing pressure there and then letting go can cause changes in the blood pressure. When we're just inspecting the carotid pulses, any kind of bulge or tortoise could indicate a kinked carotid artery. A weak carotid pulse can indicate decreased stroke volume, and increased carotid pulse can indicate increased volume pressures. When we're inspecting the carotid artery, we also want to note any thrills, vibrations, and when we get to the auscultation part, we'll also want to note any bruits. The next thing we're going to do is assess the brachial artery. We'll do this by just having the patient's hand relaxed and then assessing the brachial artery midline to this mid-sternum. Just like assessing any artery, we want to inspect for any pounding or threadiness and irregularities. And in patients that have weak carotid pulses, the brachial artery is also the next line that we use for assessment, for the cardiovascular assessment. Okay, and those were the normal limits. The next thing is we're going to assess for JVP, or just jugular venous pressure. And we do this by having the patient turn their head slightly to the opposite side. We're going to look for any pulsations or indolations in the JVP. We're going to measure these using 2 centimeter rulers, 15 centimeter rulers. We're going to look for the highest point of indolation, which is about right here. And we're going to take one and have it horizontal to the sternal border, mid-sternal border, and we're going to make a 90-degree angle. So that is exactly at 3 centimeters. Normal is less than 3 centimeters. Anything greater than 3 centimeters, it's an indication of increased left ventricular end-diastolic pressure and low ventricular ejection fraction. Also, if there is indications of heart failure, we can do a hepatojugular reflex. Patient shows no indication at this time, but I will go ahead and demonstrate those steps to test the hepatojugular reflex. We do this, I'm going to cover the patient up. Because privacy is very important. And I'm going to show the abdomen. I love you. We're going to take the patient supine for this procedure. We're going to take our right hand with our fingers and we're going to point it upward towards the patient's head in the right upper quadrant. And that's just below the costal margin. So we're going to press there and we're going to have hold pressure for about 30 seconds. This maneuver, what it does, it forces the blood up into the great vessels. And normally, the normal person can pump this blood extra through their heart within 2 seconds. So that's good. Okay. And now we're going to examine the heart, which is a great portion of the cardiovascular health, advanced health assessment. So we're going to just look at the pericardium. We're going to note and see if there's any heaves or lifts. or any extra movements. We're going to palpate the apical pulse, and we do this by finding midclavicular line, 5th intercostal space. And in the females, especially large-breasted females, we may have to displace the breast, or we can ask the patient to do that at this time. So I'm going to go midclavicular line, 2nd intercostal space, 3rd, 4th, and 5th. In this instance, I'm going to have the patient displace her breast. Just lift it up for me, thank you. And we're just going to palpate that apical pulse. And we can do this by using 2 pads of our fingers. When we palpate the apical pulse, we want to note any thrills, the diameter of it, the amplitude, and this is also a great way to assess the heart rate, also known as the apex of the heart. And good, that's within normal limits. We're going to palpate the precordium, noting any heaves, lifts, and we can do this with the pads of our fingers. We're going to palpate the right side. This is the aortic area. If we do feel any thrills, we can listen for murmurs. We're going to palpate the left side. And that's good. No thrills were noted, or heaves were noted at this time. Now we're going to palpate the aortic area, which is the 2nd intercostal space on the right side. We're going to note any heaves. None were noted. We're going to go to the left side, and this is the pulmonic area. We're going to note any heaves at this time. None were noted. We're going to go to the 3rd intercostal space, and this is also the 2nd pulmonic area. We're going to note any heaves. And then the 4th and 5th intercostal space, just mid-sternum, is the tricuspid area, just to the left of the sternal border. I'm going to have the patient displace her breast for me. And this is assessing the tricuspid area. We're also going to assess at this time for any heaves. And then we've already assessed the apex, and there was no heaves noted at this time. I'm going to have the patient turn to her right side, just a little bit. I'm going to palpate the apex of the heart. This pushes the left ventricular forward. If there was any S3, S4 sounds when we get to auscultation, we'll be able to listen at this time and know any extra sounds. It also allows us to feel more accurately if there's any heaves in the aorta. And that is normal. I'm also going to have to help the patient to sit up forward, leaning forward slightly. And I'm going to also palpate again. And these are within normal limits. You sit up for a second for me. Having the patient lean forward, this brings the apex of the left ventricle forward and closer to the chest wall. And it elevates the PMI and it allows us to detect if there's any aortic insufficiency. I'm going to go ahead and listen at this time while the patient's sitting up to the apex of the heart to see if I can hear any murmurs. So I'm just going to slide under the patient's gown. I'm going to keep our privacy for this video. And I'm going to listen to the apex of the heart. Everything was within normal limits. I'm going to have you lay back down now. Now I'm just going to listen to the heart sounds where I palpated. I'm going to go to the second intercostal space and listen to the aortic area of the heart. Going to the left side of the second intercostal space, listening to the pulmonic area, noting for any murmurs, any extra heart sounds. And you can more adequately hear a S3, S4 sound with the bell of your stethoscope. So I'm going to switch that over and go back to the right side and listen to the second intercostal space for those. I'm going to go to the third intercostal space. This is the second pulmonic area. The fourth and fifth. This is the tricuspid area. And I'll ask the patient again to displace the breast for me, and I'm going to listen to the apex of the heart. In the fifth intercostal space, mid-clavicular line. Thank you. When listening, like I previously stated, we want to listen for an S1, S2 sound, which is lub-dub. With the bell of our stethoscope, we listen for an S3, SV4 sounds, which are extra sounds. We listen for murmurs, and we listen for any extra ejection fraction sounds, or we noted the timing of the S1, S2, the splitting of the S2, S1, S2, and those were all within normal limits. Okay, and this concludes our advanced cardiovascular physical assessment.
You want to turn it off?